I'd like to introduce imminently here Laura Parahone, who's going to do a little bit more brief overview of what's going on in vaccines. This is by design, because actually it turns out there's a lot more going on in vaccines this week than any other weeks in recent memory, but she's going to go through that quickly. We're going to talk about cases, do a deeper dive into what's happening in our hospitals, where Jennifer Vosberg is really going to be helpful to us, and then have an announcement about next steps here in New Mexico. So with that, Laura, I'm going to turn over to you to update everybody on where we are with vaccines so far and what's coming up in the next few weeks. Thank you.
Absolutely. Thank you so much. All right. So hi, everybody. Thanks again for tuning in today. So for our vaccine progress update today, once again, go New Mexico. We're at 81.1% of all New Mexicans 18 and over, and 62% of 12 to 17-year-olds have received at least a first dose. So that's really exciting. And then we continue to slowly but surely increase the number of New Mexicans fully vaccinated at 71.6% of New Mexicans at 18 and over fully vaccinated, and 53.5% 12 to 17-year-olds. And then 5.3% of New Mexicans, you can see that on the on our dashboard now, have received a booster dose. Those 18 and over. 12 to 17 are still not yet eligible for boosters. Next slide. So here's a little update on booster dose administration in New Mexico. We continue to effectively administer the Pfizer booster doses, which is the one that is approved right now. Since August, we've had 81,364 doses delivered. And then since September 24th, when we had the booster doses, over 58,000 doses have been delivered. So you can see we're steadily increasing those. So thank you to all of you who've gotten your booster shots. Next slide. So this is really exciting. It's been a busy month for vaccines. These are the anticipated boosters for Moderna and J&J. Next slide. You can see in the news that the Moderna boosters are really making their way through the federal approval process. Most recently, they had a unanimous vote that recommended, the FDA recommended authorization of the Moderna dose at half a dose for the booster. And really the available data support the safety and effectiveness of this vaccine for the same group as the Pfizer group. So 65 and over, those who are in long-term care facilities, so all our nursing homes, 18 to 64-year-olds with high risk of severe COVID, and those 18 to 64-year-olds with heightened job and institutional exposure, that put them at higher risk of COVID. And then at least you have to get it at least 6 months after the completion of your primary series, and they will meet again. The ACIP will meet on the October 21st to make recommendations regarding the Moderna COVID-19 booster doses. And we predict that if that happens, then by the end of this week, we'll be able to actually have the whole approval process for the Moderna vaccine. Next slide. Same exact thing for the J&J booster dose approval. So hopefully by the end of this week, we'll also have the final approval for J&J and those who are 18 and older. And then at least 2 months after a single dose of the primary vaccine will also be available. So a lot of people I know were worried about the J&J initially, but the actual improvement after you get your booster dose is actually 94% effectiveness. So that's really exciting for all of those who have gotten J&J. So next slide. This is exciting COVID-19 vaccines for 5 to 11-year-olds. So next slide. Clinical trial results, like we've been sharing, shows that the Pfizer vaccine is super effective and safe for 5 to 11-year-olds. They looked at 3 groups, 5 to 11-year-olds, 2 to 4-year-olds, and 6 months old to just under 2 years old. And they have found that these smaller doses for the children are extremely effective. Next slide. The Pfizer Pediatric COVID vaccine is super exciting for pediatricians because they will be delivered in smaller doses and also in sets that are smaller packs that can be extended in your refrigerator. So if you are a pediatrician and you haven't signed up yet to be a Pfizer vaccine provider for your kids, this is the time, because you could just go to takecarenewmexico.org, sign up, and like I said, it's smaller doses, it's smaller packs, and stay in your refrigerator longer for your kids. Next slide. Oh, whoops. Okay. Okay. Great. So in the next slide, it just shows the process for 5 to 11-year-olds. The EUA basically got a little bit scrunched, but October 26th was the review and recommendation, right, by the vaccines FDA committee. Then the next step is the FDA approval sometime early this week. Then review and recommendation by ACIP, the Advisory Committee on Immunization Practices, on November 2nd and 3rd. Then review and final approval by CDC, and then review and approval by the New Mexico Medical Advisory Committee. So we really think that we'll probably have vaccines for children by early November. So that is very exciting. Next slide. Okay, great. There it goes. It filled in. Okay, thank you, Brianna. So vaccinated, the unvaccinated is still our #1 priority. So New Mexico's 71.6, a fully vaccinated rate for 18 years and older, has really helped protect our children, while other states have seen a huge surge in hospitalizations amongst children and adolescents since the rise of the Delta variant, with 10 times increase in hospitalization for 0 to 4-year-olds and 10 times hospitalizations among unvaccinated adolescents. We haven't seen that in New Mexico, which is exciting because we have had a great uptake of the vaccine. So vaccinating 5 to 11-year-olds for us presents such an exciting opportunity to really increase community immunity in New Mexico. Say that 3 times fast. So anyways, so even though kids, get sick less often and die less often, they can still contract and transmit COVID at the same rate as adults. So vaccinating kids will really also help us protect our adults. And as a family physician, we take care of lots of kids. And for us, and also I imagine for other people who are parents of 5 to 11-year-olds, it is just so exciting to know that this is an opportunity for us to support kids of all races and ethnicities and from all walks of life, because this vaccine will be free to everybody, just like the other vaccines. It's proven to be safe and effective. You don't need insurance or ID. We're making it available all over the state. So really a great opportunity to vaccinate this really unprotected currently group of people, which are 5 to 11-year-olds. So really exciting for me as a family doc and also as a mom. Next slide. So you can schedule your COVID vaccine appointment today. If you're unvaccinated, like I said, it's the best way for us to stop the pandemic. You can schedule your vaccine appointment. We're also taking appointments for eligible booster recipients, and parents of 5 to 11-year-olds are really encouraged to register ahead of time at vaccinenewmexico.org. And also for those who do have difficulty getting onto the internet, we always have the call center. So thank you so much for getting vaccinated in New Mexico. And I'm going to turn it over now to Dr. David Space. Thank you so much.
Thanks so much, Laura. That's really helpful. Matt, could we spotlight the ASL interpreter? They're not being seen on Facebook, and we want to make sure that they can be seen.
I will work with the tech team to do our best.
Thank you very much. So I'm going to go through what's happening with COVID. Unfortunately, we're now in week 6 of a plateau or a gradual rise in cases. This is, if you're new, each blue line is a day in the COVID pandemic, going all the way back to March 10th when we had our first case. You can see that we've been through the big wave, and now we're in another wave that unfortunately is just as crushing to our hospitals as that big wave was. And we'll see a little bit more about that as we go on. You can see there that the last 1, 2, 3, 4, 5, 6 weeks have not really been much other than flat. And actually toward the end there's a little bit of an uptick in the trend. If you take those last 6 weeks, including the one in the gray area, the next slide is sort of a close-up view of just that time period, the last 6 weeks. And you can see that typical Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, we filed the test by the date they were collected, which is different than what we report in the press releases. That's the news of the day, test results that we got in. And you can see here, actually, if you look at the last 3 weeks that aren't in gray, a steady upward trend in cases. Brianna, maybe you can highlight that rather than what we were hoping would be what we thought was a leveling off or maybe even downturn. The reason we don't look in the gray area is that those numbers can only go up, and they do continue to go up like many of the other curves. And so unfortunately, we are stuck at a level of disease in New Mexico that, as we know, is primarily amongst unvaccinated individuals that is more than our hospital systems can currently handle. Next slide, please. We have the CDC now model of red, orange, yellow, and blue. And while as in past weeks, we've had some, a little bit of orange, occasionally a yellow county or two, those are all gone now with this upward trend. Virtually every county has had a high rate, and these are sort of ranked. If you look at the total new cases per 100,000 people, we want that number to be below, 10 if we can get it. And you can see the closest county is a small one at 15. And so, and Harding, very small county at the bottom with 282 cases per 100,000. They don't have a lot of people in Harding. And so a small number of cases does push their numbers up. They've been orange in the past, but not this time. So this, again, putting undue stress on our hospitals with this case count. Next slide, please. In addition, we're back above the 7.5 target for test positivity. Usually what that translates into for us in DOH and the epidemiologists in particular is a loss of confidence in our case numbers. And we're really close to the line. So I think we're doing pretty well on with our data. But once you get above 7.5, the chances are very good that you're missing cases. People aren't getting tested. And so we do want to call on New Mexicans. I don't have 3 or 4 slides focusing on this today because that is not our area of focus, but we want to get that back under 8.1%. We want to be below, ideally 5 if we could. And the only way we can do that is to have everyone get tested who has symptoms, has had contact with someone who tested positive, or has other reasons or concerns for being tested. And it's easy to do now. You can get tested in your own home, even if you like, through one of our testing agencies. Next slide, please. So hospitalizations and deaths, and we're going to spend a lot of time today on hospitalizations, and I'll introduce Jennifer to you in a minute, but let's go to the next slide. This is hospitalizations in New Mexico, and we've labeled for you December 4th, and I think the official public health order was December 9th when we enacted crisis standards of care. We were at a peak. And I think it's important to just pause for a minute and say, well, how can things be so bad in hospitals when it seems like the number of COVID admissions is less than half of what they were before? And the answer to that question is that people in the hospital are as sick as they've ever been, sicker actually than they've ever been. And we have a lot more people in the hospital right now with non-COVID related illnesses, some of which we believe are related to delays in care that occurred during the worst part of the pandemic when people were staying away from hospitals and even sometimes facilities were closed for outpatient care. So next slide then, Brianna. This on the left is this curve you're used to seeing. You can see the, we were in crisis standards of care last year. You can see we've been on that line or above the line between orange and red for quite some time. We've gotten some questions, well, what goes into the scoring system? And so, and we'll show you last week's scoring. The things that got red were the fact that we were having to delay care and limiting it only to critical services. We were unable to transfer very many patients because of the full nature of our ICUs. And our transfer center was up and running, which of course you all know has been since July. Triage and allocation, we're on full activation of all of our triage resources. Emergency departments in general are saturated with long waits and record numbers of people leaving before they're even being seen. Our ICUs have been greater than 100% utilization as a state for weeks and weeks now, probably 4 or 5 weeks. And non-ICU beds also at or above 100% capacity. Our modeling actually will be red this week as it has that upward trend. And but last week it was in the orange range contingency. We were unable to redeploy staff from one place to another to meet the needs of patients, and tiered staffing, that right now we don't have people, healthcare workers with COVID actually in the hospital actively treating people with COVID. That's sort of a desperation move. We have not had to go to that yet. Capacity of our staff is insufficient to maintain all of the patient care and all the beds that we would otherwise like to be maintaining right now. Staff ratios, we can't go any further with our staff ratios than we've already done. And then supply chain, actually having some issues with supply chain for things like IV fluids with 5 or 6 dozen ships sitting off the port of LA out in the ocean waiting to be unloaded because of a shortage of dock workers. And so that's starting to affect our hospitals with routine supplies that are used to take care of COVID patients. And we still have some recycling in place if we need to for PPE. That's no longer a crisis. That PPE one, the last one was read last time. So in most of these things, we're in a significant dilemma with our ability to be able to provide care. Next slide, please. These usual maps, I think we're back to the worst we've been with only 11 ICU beds available as of first thing this morning. Those are probably all full by now. You can see none up in Farmington, which is a particularly hard hit area right now. And our thoughts and prayers go out to all the healthcare workers in Farmington. If you look at that box for Albuquerque, only 2 ICU beds open, and I believe that's at Sandoval Regional Medical Center. And so a really tense situation. On the other hand, we've had a few more general medical beds. You can see 87 total. And so what we're trying to do right now is push people who normally would need ICU care down into regular medical bed care. Of course, that's pretty difficult to move someone from an ICU on ultra high flow oxygen that requires almost continuous monitoring down to a floor bed where a nurse has to take care of perhaps 6 or 8 or even more patients, depending on which shift they are working. And so this is a major crunch. We have a major shortage in ICU beds. We showed you week before last the consequences for that man from Oklahoma who died because there was no ICU bed to transfer him to from Taos. And frankly, in any other state, there was no ICU bed as well. Next slide, please. This is just the past 4 weeks. About 90% of deaths we've had from COVID are in people who are unvaccinated. And you can see 82% of hospitalizations, 76% of cases. We are having people who are already vaccinated who are getting COVID, and hence the push that's on now for booster shots for people to try to boost that immunity and increase their resistance. Hospitalization numbers don't surprise me as much, even though they're higher because of what we're seeing in the hospitals. Hospitals completely full if, completely full if of people who have either delayed care or just have really serious disease. This could be heart disease, intestinal bleeding. It could be out of control diabetes to the point of being in a coma, all things that simply can't be managed as an outpatient. And so it is true that we have less COVID patients in the hospital this time than last time. But when you look at the people who are in the hospital with COVID, again, 4 out of every 5, more than 4 out of every 5 remain unvaccinated. And that is one changeable thing we could do to actually get us out of the crisis that we're in right now. Next slide. We went back and did some math. This now is from February 1st to October 11th. And Dan from the Albuquerque Journal, if you're on my estimated math I did last time, I took the date of reported deaths rather than the date of actual deaths. But since 1 February of this year, there have been 1,039 deaths in New Mexico. 967 of them are preventable. So almost 1,000 people have died in New Mexico since February 1st that didn't need to die had they been vaccinated. And that really is a tragedy. It's something that's avoidable. And again, I respect everyone's right to make a choice. I actually saw patients today. I don't recommend seeing patients on the same day as a press conference because our Wi-Fi went out in my office, and I drove back up home here at home in my office to do the press conference today. Spent some time talking to my only unvaccinated patient. She's just waiting for a different type of vaccine to come out, so she will take it. But I'm very concerned about her health and what will happen to her if she gets sick with COVID. We heard about Colin Paul today. Sad death of one of America's great heroes who died from complications of COVID. He was vaccinated, of course, but nonetheless, this is a devastating, terrible disease, and we all need to do everything we possibly can do to get this under control. Next slide. The CDC came out with a really interesting slide this week that's similar to the data that I was showing you. They go back to January 30th. We did not coordinate our efforts. We went back to February 1st. And this shows the rate of hospitalizations, the rate. So, and they're adjusted for age. So it wouldn't matter if you had more or less old people or young people at a given point in time. And you can see the green line is this extremely low chance of being hospitalized. It's gradually crept up to something like 5 in 100,000. And then you can see the blue, and that's in vaccinated individuals. And the blue line here is the rate per 100,000 population, again, age adjusted, people over 18 from January to August, hospitalization rates for the unvaccinated. So we're seeing the same thing that we've seen elsewhere. COVID-Net as a CDC specialized data collection system, electronic system. New Mexico has been part of that collection system, one of only 14 states, and there are hospitals. New Mexico forwards the data along from DOH. And so we are really enjoying some of the best data in the country. But I certainly wish, at least at the present time, we were seeing better results. Next slide, please. Just an update on the number of New Mexico hospital workers that are vaccinated. The reason it can go up and down as a total is because we get different levels of reporting each week. I think we had 90% last week. But what you can see, the green bar last week on October 10th, almost 88.5% of New Mexico hospital employees are fully vaccinated, with another 3.33% partially vaccinated. There's about 7.5% of folks out there who have an approved exemption, and exemptions were allowed under the vaccine requirement public health order, and only 67/100%, 2/3 of 1% of healthcare workers remain without either a vaccination or an exemption. And so, and it's gotten to the point that that number is so small. Brianna, if you can point to the red bar on 9.5 over on the left, all the way to the left, you can see it's visible. You can actually see that number, and then you can see it pretty much disappear by the time you get to the end of the curve. And so that's another 3,000 to 4,000 healthcare workers that have been vaccinated as a result of this. And we think that is keeping much of our healthcare workforce still in action, not missing work because of COVID infections. We all know from early in the pandemic that healthcare workers have some of the highest infection rates of anyone. And then sadly, this week, we will, in all likelihood, surpass 5,000 deaths. And if you go to the next slide, Brianna, you can see the number of deaths per week with that 4-week lag as we get new information in. So the highest so far is over 10 a day. And again, we expect to continue at about that rate for at least another 4 weeks until we see case counts come down. And again, just the fact that so many of these deaths are unnecessary is just a real tragedy for New Mexico as a state and all of the families who've been affected by these unnecessary deaths. Next slide. Treatments, really pleased to see this. Remember, on the left, we have remdesivir, which is given to people in the hospital. And you can see we're at our highest rates of remdesivir use actually this year. This only goes back to July, but we're doing well, almost everyone who gets admitted. But then on the outpatient side, and we've really been pushing this, you can see there are 2 different types of antibody treatments that are in use right now, Regeneron and what we call BAM-EDI. And BAM-EDI is the red bar at the bottom on the right-hand side of the curve. When you add those 2 together, we're at the highest rate of treatment of those who are COVID positive, have COVID symptoms, are over 64, or they're obese, or they have any risk factor for serious COVID disease. This is given as an outpatient. We're working with FEMA to come in and do freestanding administration because our hospitals are as busy as they can be. But this is a success story. And in our modeling team last week, Los Alamos National Labs feels that about half of the gap in hospitalizations, in other words, half of the reason we're not seeing much higher hospitalizations with the case counts that we're seeing is because of the administration of these antibodies. So I'll remind you at the end that if you're COVID positive and have symptoms, and then you're older or obese or have any risk factor for serious disease, please immediately seek out treatment. Next slide. I wanted to just thank again Presbyterian and Norlee, who continue to be the leaders in giving these treatments, but also 3 other facilities that are stepping up. And some of these are pretty small hospitals, Gallup Indian Medical Center, Gerald Champion. So kudos to you for providing this important treatment to people and keeping people out of the hospitals. Next slide, please. With that, I am going to hand this over now. And Jennifer, if you turn on your camera to Jennifer Vosberg, she's the Associate Chief Nursing Officer at UNM Hospitals and primarily has been focused on flow and patient throughput. She's been participating in our MAD operations team, the one that meets so frequently early in the morning since the beginning of this recent Delta surge, and oversees on behalf of DOH, who is the official entity running our transfer center. Jennifer's married, has 2 boys, and she's busy trying to keep up with them when she's not at work, which I don't know when she's not at work, because like many of us, this latest Delta pandemic has really put a strain on our hospitals. So Jennifer, Brianna, why don't we go to the next slide? And Jennifer, I'm going to turn it over to you. Thank you.
Good afternoon. Thank you, Secretary Scrace. Again, my name is Jennifer Vosberg. I'm a nurse at University of New Mexico Hospital, and I'm going to be representing the State Call and Transfer Center. I'm going to take a few minutes of your time to talk about our current surge in the state of New Mexico, as well as our current staffing situation. So part of my role with the State Call and Transfer Center means that I get to partner and meet several times a week with nursing leaders and hospital leaders throughout the state. And unfortunately, the message is the same. As nursing leaders, we are struggling, we are frustrated, and we often find ourselves in a position to make the least bad decision that we can. It wears on us, our staff, and our patients. What I'm going to be talking about is not unique to one hospital, but is a statewide struggle. And as Secretary Scrace mentioned, this surge is different this time. While the COVID numbers are not as high as they were historically, and certainly not what they were in the winter, thanks to the mask mandate and vaccines, most hospitals never saw a reprieve from the prior surges, and many patients are coming back sicker and more complicated than ever, largely related to a delay in care. This, of course, is further exacerbated by a reduction in healthcare resources. So you can see on this slide attached, this is the New Mexico hub and spoke model for the transfer center. So the call center was initially established in March of 2020 with the sole purpose of level loading the ICUs, meaning we didn't want one hospital, as an example, in northern New Mexico to be surging with patients while we had another hospital, let's say in southern New Mexico, with plenty of capacity. The goal was to have everybody at the same percentage of occupancy. And you can see from this graphic that all of the spoke hospitals tend to be the smaller, more rural hospitals, and they all feed into a larger hub hospital. So the hub hospitals are the hospitals that we meet with regularly and make sure that we have what we need as a hub to support our spokes. As Secretary Scrace mentioned, this was just one of the strategies deployed to ensure that we were optimizing both our physical resources, but our human resources. It's also fostered some real collaboration and partnership amongst the hub hospitals throughout the states. One example that came around earlier on was we had a hospital, a hub hospital actually, that was running low on ventilators. Because of our partnership and collaboration, there was another hub hospital that had some extra vents and they were able to share. And within several hours, we were able to get those vents to the hub hospital that needed them and ensure that our patients had what they needed to receive the care they required for their hospitalization. During our winter surge, which again, Secretary Scrace showed the graphic, we saw many, many more COVID patients than we have now. The call center was always able to place the ICU level patients. Sometimes it took a little longer than others, but we always were able to say, yes, we will find you a bed. This surge is not like that. We are often finding ourselves saying, no, we don't have a bed. I'm so sorry. Please call back tomorrow. This is very distressing. This is not what we got into the business of healthcare for, and this is very hard for our nurses at the call center. Our nurses try to reconcile the list of calls they receive every 24 hours and do a little loop closure following up. And oftentimes when they call and say, hey, were you ever able to find a bed? The answer is no, and often it is, and the patient died. This is very, very distressing for our staff and for all of the healthcare workers in the facilities that can't provide the care that they were trained to do. Next slide. So you can see from this graphic, there's two levels. There's the ICU capacity, and then there's the non-ICU. You can see that the majority of the hospitals are well above 100% capacity, and those that are not are working diligently to get the resources to get there. But what that means, if you're a patient, is that we have to be creative in how we care for you. Many patients are assigned to hall beds, or they spend their stay in a doubled room that was never intended for two patients. We have patients who spend their stay in the operating room or an interventional area such as the cath lab. These spaces were never intended for long-term patient care. There are no bathrooms, there are no TVs, there are not the normal patient room requirements that patients expect. Not only is there a lack of beds and clinical space, but these patients are sicker than ever before. All of us track acuity within our organizations, and our acuity has seen a steady increase despite the waxing and waning of COVID cases. And again, this is due to the delayed care and that patients are sicker, so they spend longer in the hospital and it takes longer for them to free up the bed. Additionally, as Secretary Scrice mentioned, we are in a situation now where we downgrade patients to non-ICU level, where historically that would have never happened. But we do this so that we can free up ICU space. And emergency departments are no different. Many hospitals across the state are seeing higher than normal ED volume check-ins, which alone is problematic because the system wasn't built for these current volumes. But an increase in volume also means longer wait times, an extremely dissatisfying experience, and people leave without being seen. And we know when you leave without being seen, you oftentimes come back sicker and in worse shape. Next, I'm going to talk about staffing. While we're grateful for the vaccine mandate and booster availability, it definitely helps us feel better about going home to our families, and it makes us feel more confident caring for and protecting our patients. Many nurses have retired as a result of the pandemic. We also know of multiple newer nurses that have left the field of nursing because of the pandemic-related stressors. While we've only lost less than 1% of nurses to this vaccine mandate, the problem of the shortage continues. And to be clear, we had a nursing shortage prior to the pandemic. However, we are now at crisis levels. We are in a position where the demand significantly outstrips available resources. This is particularly bad in rural New Mexico. Because of the lack of resources, many of these facilities have had to close areas, including ICU beds, which then further exacerbates the overall capacity and compromises care, especially to those in rural New Mexico. We are all working to bring in contract labor, and unfortunately, we're all competing for the same limited resources, both locally and nationally. Healthcare workers, especially nurses, are just getting crushed in this current environment. We have more patients to care for in less than ideal spaces. And understandably, the patients are frustrated that they aren't being cared for in the spaces that they deserve to be. Many nurses are working in ratios that are higher than normal with less available support services. As an example, there's a shortage of phlebotomists, respiratory therapists, and physical therapists. All of this is in addition to caring for patients that are sicker than they've ever been. Ultimately, patients are not getting the care they need and deserve in New Mexico. This is counter to everything we've been taught to do as nurses and the reason we went into healthcare. This is leading to an overall sense of helplessness and feeling overwhelmed each and every day. There is a perceived sense of a lack of concern by the general public, which lends itself to the sense of hopelessness and feeling that normalcy will never return. I am proud to say that I've been at UNM for 20 years, and I'm honored to care for the population we serve. However, we are in a place where that is being compromised. We are in a crisis right now in the state of New Mexico. We need to get control of our COVID cases immediately so that we can focus on the New Mexicans that need and deserve the care that we once provided. Our nurses are exhausted and losing hope that we will never find our normal again. We did not go into healthcare to say no, but to help anybody and everyone who needs it. Please help us help you and get vaccinated, protect yourself, your family, and protect New Mexicans. Thank you for the chance to be here and share with you. Before I turn it over to Secretary Scrice, I'm going to show a quick video by two of our statewide nursing organizations that shows a bit more about the current nursing situation.
"122 years ago, a nurse named Clara Barton was the
Hey,
hero of the
Brianna, you need to
Johnstown
share
Flood.
your screen.
Today, in a global
Switch to the video and then start over. Thanks.
health crisis that's claimed 122 years ago, a nurse named Clara Barton was the hero of the Johnstown flood. Today, in a global health crisis that's claimed over 4,600 New Mexico neighbors, nurses are still doing heroic things, fighting back flood waves of fear. Over 1,100 American nurses have already died during the pandemic, a sacrifice that didn't have to be so deep. And a nursing shortage has become a major threat to public health. Fewer nurses mean there's no one there for patients. Here's what you can do now to help keep New Mexico safe. When a mask is required, listen to the health professionals, and please get vaccinated. While the debate rages on protecting personal freedom and public health, do your part voluntarily. Protect yourself, your family, and healthcare professionals.
I'm wondering if someone watching me right now could be the next Clara Barton. Nursing is a profession that desperately needs more people. Fewer staff right now means there's no one there to take care of patients who need us. It's a job with risks, but it's incredibly rewarding. There's nothing like taking care of a person when they need you the most. You won't regret the decision to join the profession of nursing.
Well, thank you very much, Jennifer, for that overview. Jennifer's has just done an amazing job heading up our transfer center. You can imagine the frustration last year being able to move people eventually into beds, but this year struggling to do so. So we're going to go into the next slide, and I'm going to start talking about crisis standards of care. I just got a tweet from the Albuquerque Journal that we're doing this. So I think that we must have released a press release right about the time of this conference today, which is just great. So let's go to the next slide briefly. I'm going to review, we've been through just even in the talk today, but certainly over the past 2 or 3 months, everything we're doing in New Mexico to try to mitigate the effect of the Delta variant, and things like vaccines. We're still in the top 10 in terms of our state vaccination rate. We learned a month ago or so from the CDC that in getting adults vaccinated, we dramatically reduced the chances of kids in New Mexico being hospitalized. We mandated healthcare worker vaccines to preserve our healthcare workforce. 2 weeks later, that became a national mandate from the current administration. We've been trying everything we can do to get boosters out to people, making those available, and encouraging our primary care physicians. MAB treatment, monoclonal antibodies, we're doing great, and already showed you that data. Testing, we continue to do well with testing. We could do a little bit better the next couple of weeks, but we also lead in genetic sequencing. We haven't shown you those genetic sequencing frequency maps because Delta has been 100% of our cases since July, and that hasn't changed at all. And then I think I'm particularly proud of all of the work that our delivery system partners have done to actually knit 4 dozen hospitals in the state of New Mexico into a single sort of hospital ICU system where we can level load and move people back and forth. But as you can see right now, we're in a bit of a gridlock. And so going forward, we're going to continue to do everything I just mentioned. We have already connected hospitals with FEMA. FEMA is willing to pay extra dollars for this very nationally competitive market for travelers, nurses, although frankly, I think a reporter from a national chain contacted me 3 weeks ago, like asking me if I was frustrated with the federal government for not sending New Mexico all the resources we needed in terms of nurses. And I said, well, they can't produce nurses out of thin air. We're desperate. There's a national shortage, and it might even seem a little corny to try to recruit nurses at a time like this. But that call is not just for people making career choices to go into nursing, but if there are any nurses out there who've retired or stepped back or needed to take a well-deserved rest during COVID, we would invite you back now. We need you more than we ever have before. The state's in the process of finalizing a contract with an external agency to see if we can find and recruit more nurses to the state. I mentioned FEMA coming in to expand monoclonal antibodies, and now today we're announcing by way of a public health order that I signed, about an hour ago, to enact crisis standards of care here in our state. Now, we did this once before, and I showed that to you earlier in December of last year, but let's go to the next slide, Brianna, and you'll see there, really what is going on is there has been a substantial change in universal healthcare operations. You've heard about our struggles to provide care, deliver it, and it could be made necessary by something pervasive, like pandemic, influenza, or catastrophic, like a natural disaster. I mean, COVID, frankly, is both pervasive and has a significantly high mortality rate to move it into a combination of those two. We're not declaring that from now on, we're going to crisis standards of care. DOH is saying, hey, we're having to make these tough decisions already. Our resources are scarce. We're trying to ration care. And so we're now formally declaring that that is what is going on and that will be what we will all be doing in the state over the next 4 weeks, which is the period of time that the order lasts. This also enables some specific regulatory protections for certain, not all, but certain healthcare providers, and allows us even more flexibility to make decisions about using resources. And I think one of the things we realized is that nobody really remembers very much about what happened back in December, shortly after we announced, if you will, and issued the public health order for crisis standards of care. Things began to let up, and we didn't have to decide, we didn't have 3 people and only 1 ventilator. There was a particularly long night where it looked like we could be in that situation, but we were able to get through it. So on the next slide, I'm just going to go into a little bit more detail. In particular, what does this mean for the average patient or provider? As Jennifer so eloquently put it, nurses and doctors and respiratory therapists and many people are agonizing over these difficult choices for care. And under crisis standards of care, facilities all across the state will be able to use a more standardized and equitable procedure for making those decisions, for evaluating patients. And it isn't every facility in the state all at once goes into this, but a single hospital may invoke crisis standards of care for a period of time because they're not able to handle the volume of patients or the complexity of patients. And under this declaration, similar to last time, before a facility gets to this point, they have to suspend non-medically necessary procedures. The state is not closing down medically necessary procedures, but we're saying to hospitals, if you get to the point where true care rationing is happening, then you have to suspend those. And the definition this time around is a little bit different for non-medically necessary procedures. We've made it, depending on your point of view, either much more simple or perhaps even more complex. But we're saying that the treating provider is the one that decides if something is medically necessary. And I know in conversations with the governor that she feels that, like, for example, if someone has an abnormal mammogram with a suspicious lesion for cancer, then that needle biopsy is a medically necessary procedure that should not be unnecessarily delayed. Or if on a screening for colon cancer with a stool test, there's a high suspicion of colon cancer, then that colonoscopy becomes medically necessary. And so we don't want to go through another period where we close down care and see the kind of rebound we're seeing now with delayed care. And I believe this rebound may last for quite some period of time, not just measured in days or weeks or months, but even in years, as we all catch up with our needed healthcare and our needed procedures. Next slide, please. In acute care settings, And when hospitals go into crisis standards of care, if hospitals choose to call up different kinds of treating providers, and this mainly applies here to physicians just because of the way the laws and the boards are constructed. But folks who move, but it could be nurse practitioners or physician's assistants as well. Anybody who moves from a less complex to a higher level of care can apply to the Department of Health like last time, and they will essentially become considered an employee of the state for legal coverage and liability coverage during that period of time. Next slide, please. And I want to make it really clear, I said this once, but this doesn't mean that New Mexicans should wait to seek care. And if you're needing care, if you have an abnormal test, don't put it off any longer. Please contact your doctor's office. Many doctors still do video visits or in-person visits, and many workups of this nature also can be done as an outpatient. Our facilities and outpatient facilities that practice very high degree of COVID safe practices. We're going to hear more from Billy Jimenez, I'm sure, in the question and answer period. He is our DOH General Counsel. He's the person who writes many of these public health orders. He was just recently awarded a half of your lifetime achievement award by the University of New Mexico and the bar for his excellent legal work through the pandemic. And the governor by video in that ceremony kind of pointed out that Billy himself had actually been instrumental in saving thousands of lives. I think that's completely true. And in addition, he even served as acting secretary for a period of time last year. So Billy, is there anything else you want to just mention here before I close about crisis standards of care?
Yeah, thanks, Secretary Grace. I think the one thing I wanted to mention was that it's really moving to this level and issuing this public health order is noting that we're deviating from normal operations in a lot of our hospital facilities. So it's a recognition on the part of the state to sort of partner with the facilities to make sure that we all recognize that we're moving to a different standard of care in the state.
And thanks so much for being with us today, Billy. I appreciate having a lawyer who understands the intricacies of the law. I'm sure we'll be hearing more from you in the question and answer period. So I'm going to go to the last slide, and then I'm going to turn it back over to Matt to host our reporters' questions. We're in tough shape right now in New Mexico hospitals, not just because of how things are this morning or this afternoon, and not just because of how things have been over the past 6 weeks, but really how things have been for over a year and the kind of stress and strain that people go through. I mentioned here before, I went and got my booster shot a couple of weeks ago. So many of my friends, it was a lot of the hospitalist friends of mine getting their shots. And even though they were wearing masks, I could see the fatigue and the exhaustion in their eyes. And I think we owe it to our healthcare workers. And I say, in all honesty, if we want to have a viable, effective healthcare system for us and our families and our kids and grandkids in the years to come, we really do need to do everything we can to support them. And whether that means getting tested, if you have any suspicion or symptoms that you might have acquired COVID again, even if you're vaccinated, remember, get tested. If you have the criteria with a positive test and symptoms, then get monoclonal antibody treatment. We could reduce COVID admissions by 75% if high-risk individuals were able to get tested. And as always, be careful indoors, keep those masks on. I know we're getting lax. Don't get lax. Keep your mask on, washing hands, coughing away from people, wearing those masks, keeping your distance, getting vaccinated above all, and then getting needed preventive health care. Each one of those things and everything we've mentioned today is something we can do to help Jennifer and her colleagues and all of our hospital workers in the state to get through this. We have to be in this together and get through this together. And with that, Matt, just a reminder again that as we pass that 5,000 death mark this week, the idea that 1,000 of those deaths will be in unvaccinated people since February 1st, to me, is just an incredible tragedy, especially if you think that maybe only, 100, 150 of those deaths will be in vaccinated people. So this has got to stop. There are things we can do to stop it. Let's work together to help our hospitals as we go forward. And now I'll turn it to you, Matt. Thank you.
All right, thanks so much, Dr. Scrace. And just a reminder, a welcome to those of you in the press corps that are here with us for the very first time. I see a name or two that I don't recognize. So if and when you raise your hand and I call on you, please do just introduce yourself and name your outlet. Just a reminder for everybody, our process here is you use the raise your hand feature in Zoom to indicate that you'd like to ask a question, and then I'll call on you and unmute you. And if for whatever reason you're having some sort of audio challenge and you're not able to ask a question, feel free to drop it in the chat and I'll ask it on your behalf. And one final reminder, which is that no need to cluster your questions. We will go through the reporters in the list here as many times as we need to until everyone's had a chance to ask their questions. So with that, I will start with Tommy Lopez, followed by Julia Goldberg, followed by Chris McKee. Tommy, you are unmuted. Feel free to ask your question.
Hi, guys. Thank you so much for doing this once again. Can you hear me okay?
Yes.
Great. So Dr. Scrace, you are again describing a situation that sounds eerily similar to what you described in December, as you said, the last time that the state moved into this crisis stage. Can you give some observations and comment on hospitals' ability to keep this up for weeks from now or months from now? Can they keep this up indefinitely? And is there some kind of breaking point? What can this state expect if hospitals are continually asked to maintain these kinds of levels of patient staffing and bed availability?
I'm going to ask everybody who's a panelist today to turn their camera on first. And then I'm going to put Jennifer on notice that I'm really going to have you be the one to answer this question with your honest opinion. But Tommy, I think, healthcare workers are a weird lot. Our training is rigorous. Many of us got less sleep during our training than we thought humanly possible. We do work often 24-hour shifts, some often unplanned, go in for a 12-hour shift and things get unstable and we stay late. So we're used to that kind of stress. There'll be a natural disaster or, a bus crash, for example, and everyone is used to flooding in to help in any way they can. But those things last for a week, or a day or two. A hurricane response might last a couple months. But in a situation like this, I personally don't think it's sustainable. Not on the individual level. I think organizations have been very creative in moving people in and out of high stress situations with scheduling, but now we're at the point where we need every single person. So I don't know. I don't like to think about breaking points, but I suppose I should. I think right now we're at a point where we don't have enough nurses, for example, to take care of everybody who needs inpatient care. We don't have enough ICU beds to take care of everybody who needs to be treated in an ICU. And so those sort of shortcomings also create stress as well. But Jennifer, what's your sense about how much longer, or whether this is sustainable on an individual or professional or organizational level?
Yeah, so I think that's a great question and certainly relevant to our situation. I don't think we can quantify a timeline. I think people are doing the best they can with what they have, and we're going to keep doing what we do. We know it comes at a cost. We know it's leading to burnout and attrition and these kinds of things. We also are relying on the hub and spoke model to support one another. And we know that there are times when different parts of the state see more of a surge than others, and we're able to help each other out. We've had a number of occasions where we've seen an overwhelming spontaneous volume in the Northwest, and they call us and say, hey, can you help us? And we transfer some patients to the metro area. And so I don't know that there's really a way to quantify when we're going to reach our breaking point. I think we are, doing the best we can, and we'll continue to persevere and support one another when we can.
And just another reminder that, I don't know, like if 95% of the remaining 20% of people were unvaccinated, that would have an enormous impact on our state. If 90% of people who are eligible for monoclonal antibody treatment actually reached out and got it, which there's also issues on the supply side of that, our capacity to do it, but we're seeing a great upward trend. Those two things could put this to a halt. And so I think I would just say, out of fairness to all our professionals who are keeping folks alive and doing as much as they can with scarce resources, out of fairness to them, we need to think about what every single person can do. And I'm not picking on people, it's just a fact. And you see the data every week that the hospitalization rates and vaccinated individuals are very, very low. I guess lastly, for the vaccinated, wait your turn, coming soon, but get your booster, and get back in line for that as well, and talk to your primary care providers about whether they're going to get the boosters, or more like, when will you get the booster so I can get it at your office? All of those things are things that we can all do to actually turn the corner with this. So it's a great question, Tommy, and I think you all are in a pivotal position as our media partners to get the word out that, in this hour of crisis, that there's still something that virtually every New Mexican can do to lower that burden on our hospitals. Thank you.
Thanks, everyone. Next, we'll turn to Julia Goldberg, followed by Chris McKee, followed by Dan McKay. Julia, you are unmuted.
Thank you, Matt. Thanks, everyone. Dr. Spice, as you mentioned, the last time the state had crisis standards of care was in December. There were no vaccines, and all the patients were COVID patients, basically. The example you gave then and now was, whether or not there'd be enough ventilators for all the COVID patients. How does crisis standards of care work when you have different types of patients, when you have COVID patients and the resources they need, and you have other types of patients with heart problems, diabetes, all the things that I assume people are in with now? Where are the kind of push and shove coming in terms of resources? Can you give some examples?
Yeah, I think that's a great question, and one we've been discussing, debating, maybe even a little bit of arguing, which we don't do a lot of arguing, but a little bit of arguing about it as well over the past couple weeks. Back in December, we did have that huge surge of patients, but still, remember, there are still people delivering babies, having heart attacks and strokes, and all sorts of other reasons for being admitted to the hospital. And these are not exact numbers because I don't have them. But as I was thinking about this really carefully over the weekend, I think the situation last year was more on the order of and again, pure estimates, 2/3 of the people in the hospital had COVID, 1/3 did not. And now that's kind of flipped. Now, 2/3 of the people in the hospital don't have COVID, 1/3 do. And so it's that surge of sicker patients. And Jennifer talked about the math we do in our delivery systems for how acutely ill people are. But, when you've got someone getting a pretty serious clot busting drug, and it's being administered to them in a hallway when it normally would be in an ICU, or someone's on a balloon pump, which is about the most serious device one can have in their body. It's for bad heart failure and very low blood pressure device outside of an operating room, for example. When those things are going on, like that was in a cath lab, that's the problem. And so I think we would have, frankly, more room if it wasn't for this burden of additional illness. And most of us in healthcare, although it's really hard to quantify because there isn't a slot in the database for delayed care, that we could put yes or no. But most of the people on the front lines, their experiences, there's just a lot of delayed care, a lot of folks who didn't attend to key health issues for a year. And they weren't bad people. They just were afraid because of their risk factors of their disease to go in the hospital and get care. And Jennifer, I know you've got some perspective on this as well. Do you want to add something?
Sure. I think that unlike like you mentioned, the first surge, we had significantly more COVID patients and the vaccine was unavailable. But at the end of the day, patients are patients, and we're gonna approach this like we would anything else. It is significant that we still have 300 plus COVID patients across the state, which is 300 beds that could be freed up. But as far as crisis standards of care, we evaluate patients regardless of their situation. Patients are patients.
Anything you'd want to add, Laura, from your perspective? Laura has been our ambassador to all the other states who are in crisis standards of care right now. She and Billy have done some meetings. We've had a lot of conversations with Alaska. And so just updating our approaches based on this difference that you pointed out. Julia, what observations would you make, Laura? You're on mute, I think.
Yeah, no, every state is approaching it slightly, differently based on their context of their situation of the different hospitals and different groups of people who are addressing the crisis. I think that one of the things that we have been focusing a lot on in New Mexico right now is to try to address also some of the equity concerns, and just trying to make sure that when we do make those decisions, every provider, every group is doing the best they can. And I think that's really something that's really unique about New Mexico, is that call center that Jennifer and her team is running, is that ability to look at everything across the whole state and having visibility on the whole state is something that seems to be kind of similar across all states, is that the more visibility you have, the more you're able to help the state as a whole. I don't know. Does that sort of answer some of the perspective?
Thank you.
Great. Thanks to all three of you. Next, we'll turn to Chris McKee, followed by Dan McKay, followed by Julie Fendak. Chris, you are unmuted.
Okay, thanks very much. I had one question about kind of the immediacy of this. If it's my impression that this seems kind of like the state enacts this broad policy and it's up to the hospital to sort of jump in if they feel the need to. Correct me if I'm wrong. But do you expect any hospital to essentially pivot towards this new, crisis standards of care immediately, sort of apply to get involved? And just very quickly as well, what should patients expect from this? Is it like, I can't get my gallbladder out for 3 months, I can't have knee surgery until next year? What may patients expect? Thank you.
Well, great questions, Chris. And on what hospitals are going to do, I think there are some hospitals out there that are so hard pressed right now that we may see some movement even this week. I don't think we're going to see dozens of hospitals converting over, but I think people have been stressed. You could argue we should have done this 6 weeks ago, but remember our modeling suggested that the curve was going to come down, and it did, but it has just stayed steady. And with the burden of illness that we're seeing in all our hospitals, statewide, urban, rural, everyone in between, it's just becoming harder and harder to deliver the highest level of care to everybody. And I'm going to let anybody else, Jennifer, you in particular, if you want to comment on what you think is going to happen, because you are the one who talks to these hospitals on the phone and your team does and tells them, no, we don't have a bed. I think what patients should expect, I hope, is maybe a little bit of a delay in some procedures. Gallbladders, if you're to the point where you need to have your gallbladder out, I think your doctor's decided that's medically necessary. And, if the operating room is full of COVID patients on ventilators, then there obviously would be a delay. But I think by changing or redefining medically necessary care in terms of the clinician's assessment, I think we'll see perhaps less delays. We don't want people to feel like, in that near the end slide I had, what does this not mean? It doesn't mean you should just delay care. You still need to get care. So I think we might see a little bit of that for purely elective things like a knee replacement that probably has to happen, but could be just as well done, in a month or two, but perhaps not. I think the main thing we want to encourage people to do is not to step back from their own relationship with their treating clinicians, and to keep that relationship going and discuss those things with doctors and nurse practitioners and PAs and others to decide what the best timing would be, rather than just carte blanche delay of something because of COVID, which is what we saw the past year and a half. I don't know, Jennifer, do you have any opinions about what hospitals might do in the coming week or two?
Yeah, as I mentioned earlier, every hospital is strained. It's to what degree each hospital can accommodate it. I think I can't speak for the other hospitals. I think they're going to have to make their own decisions. Likely these decisions probably funnel through their emergency operations centers and, require an organized, well thought out decision. But I think it really is going to boil down to the ability of each hospital to accommodate the current situation. And I know some are more strained than others. Like I mentioned before, rural New Mexico, they don't have a lot of redundancy in their services. So likely those are feeling it harder than maybe some of us in the metro area, but I can't speak for individual hospitals.
Yeah, I think one thing we might see, Chris, which we saw last time, is hospitals beginning to get some of their providers credentialed to move up to higher levels of care. We had in the neighborhood of a couple dozen actually do that last time. So we may see that process restart as well. But I guess we'll just have to, it'll play out. We'll be here every week until things get a lot better. And hopefully we'll see a turn, but please communicate with your readers and viewers and subscribers and all the other ways that people get news from you to do everything they can as well to push back this current surge.
Thanks, everybody. If it's okay with the journalists who are waiting in line, I'm going to change the order just a little bit here, just because we have a question in the chat, and I want to make sure we get all of these addressed and juggle them effectively. So I'm going to ask a question on behalf of Annalisa Pardo at KRQE, who's having a little trouble with her audio. She's got two questions, and they're about the booster shots. I suspect we'll revert back to questions about crisis standards after that, but a couple quick questions about the booster shots. First question is, this morning, somebody from our DOH comms team told her that about 350,000 New Mexicans are currently eligible for the Pfizer booster shot. And according to the vaccine dashboard, about 86,000 people, or 25% of those who are eligible, have gotten a booster shot. Do we have any thoughts on that number? Is that a high number, a low number? What do we think of the pace? And then relatedly, any update on when we could see vaccine clinics come back?
Great. Yeah, I can go ahead and take this one first, since that's what we're doing every day. So we're not quite sure why only 22% of people decided to get their booster shot. We have made availability throughout the state to get the booster shot. So in a lot of the locations where we've had opened up vaccine shots, there haven't been as high uptake as we thought. In certain of our actually city areas, so the large cities like Albuquerque, Santa Fe, and Las Cruces, people have mentioned when they call the call center that some of the seniors, which is approximately 95% of all the calls we get, are people over 65 years old to try to get the vaccine, is that they're saying that they're having some difficulty getting to local sites, like mostly pharmacies, because pharmacies don't have as much capacity. Remember back in January through April, and this is related to the crisis standards of care, right? Our hospitals were helping to give vaccines at very large sites, and we were super grateful for that. But, we're not, they're not in a situation now where they can, give those vaccines because the hospitals are full. So we do have a different situation now. We're hoping that we're in the process of getting some contracts for having third-party vendors come and help us with putting up more vaccine sites, as well as some mobile team sites. So we're not quite sure, like I said, why the number isn't as high as we would hope it would be. But remember also that there's people who should get the vaccine. So that's a smaller group than people who are eligible for the vaccine. So the shoulds are basically the people who are 65 and over, people in long-term care facilities, people with comorbidities or things that put them at risk for high, COVID. So that's a group that's about, 200,000 or so people. And then you can get it if you'd like to get it. You're still eligible. Those are people who are in institutions or places that put them at potentially higher risk. That's about 164,000. So probably about a third or so or more of people who should get it, if you added the numbers up, got their boosters. And but once again, the booster shot is just helps helps a bit more, right, for waning immunity, but really does prevent, the first 2 doses really does prevent your hospitalizations and deaths. So we still are really promoting the first shot vaccines for the unvaccinated. That's really what's going to stop this crisis of too many people in the hospital. So anyways, I think that was a long explanation, but that's what we have right now.
And there are vaccine clinics going on right now, Laura.
Yes.
Around the state, and there'll be more.
Yes.
One little math point was when we came up with the 350,000, that was for people who would be eligible sometime in October. So we still have half the month, well, a little less than half the month, maybe a third of the month left as people will come online, people who got a shot later in April. So, but I think we predicted it would be a slower uptake on the boosters, and that's sort of what we're seeing.
Thank you, everybody. Great. And Dan McKay, thanks for your indulgence there. We'll turn to you next, followed by Julie Frendak, followed by Sean Griswold. Dan, you are unmuted. Feel free to ask your question.
Hi, this is Dan McKay with the Albuquerque Journal. Can you address how the Crisis Standards of Care order will standardize the process for rationing care? Is this the system where a patient's probability of survival is the determining factor in deciding who gets an open ICU bed or some other scarce resource?
Yeah, Dan, great question. We were counting on someone to ask that question because it was hard to make up a slide with all the details in it. And I'm going to start, and I think Laura will jump in on how we've changed things a little bit. But there is a tool that's nationally standardized called the SOFA tool, SOFA. And it allows us to basically assess people's medical conditions and survivability. And what it does really is it takes off those sort of things that sometimes can be subconscious ways that physicians and other healthcare professionals make decisions when care needs to be rationed. And so it really, in a way, by heightening that awareness of just survivability only, takes any kind of decisions in healthcare that would be influenced by whether, for example, someone was disabled or of a particular race or ethnicity or age or other factors. Now, since the last time when folks across the nation were using it, there have been a couple inequities discovered actually in the tool. And I know Laura, who is one of our national experts on equity, can explain what those are and how we're doing it. But you're right, it's a way, and actually, and maybe Jennifer, after Laura's done, can talk about how we anticipate that the transfer center would be involved in this tool as well. So Laura. Unmute.
Sorry, I'm muted again. Yeah, so one of the things that we tried to do when we were re-looking at, looking at the crisis standards of care is just like David was saying, looking at the data on how scoring systems may have had an impact on people of color and also on people with disabilities. So one of the things we did on the scoring system, thanks to our bioethicist group, Rob Schwartz and Nancy Gwynn and John Bolton, was really re-look at that piece and added that chronic kidney disease, which often disproportionately affects people of color, to take that out as a factor for deciding on, the scoring, and also taking out the piece of the Glasgow Coma scale, which actually is a scale that looks at like your response to a certain number of questions on coma for people with disabilities. So those two things were added in our scoring system, but really the point of, I think from an equity perspective, the point of the crisis standards of care is to standardize how we avoid getting to crisis standards of care and trying to systematize across the system what are things that everybody can do as a community of care, of how to, like Jennifer was saying, level load and see how can we support all the different systems so we don't have to make those decisions. And I think that's one of the key points of crisis standards, to avoid those decisions and thereby fostering equity by using a community approach versus like every hospital on its own approach.
And maybe Laura, before we go to Jennifer, we do have some communication plan with providers throughout the state to help with this. Their standardization as well, and those are coming up this week, right?
Yeah, so one of the things we'd like to do, we still have to talk to the Hospital Association, and because we weren't sure we were going to go to this right now, so we are going to this. And so one of the hopes is to work with Jennifer and her team to try to see if we can standardize it by providing training and having clarity. I know Jennifer already did that in December, so we'll update that with her so that we get some of this updated equity perspective and other perspectives that people have learned by doing crisis standards of care. But yeah, one of the things that was shown in the data around crisis standards of care is that when you everybody has a clear understanding of it, then you actually can have better outcomes for the whole state. And I know Jennifer's already done a lot of that, but just adding some of the other pieces to this will be our hope.
Great, thanks everybody. Next we'll turn to Julie.
Matt, I think Jennifer might have had some comments about how this tool will be used or assessed or discussed when people call to make a transfer to the transfer center. Jennifer.
Great, my apologies, Jennifer.
No problem. So when we went into crisis standards the last time, we did train all of the staff in the transfer center on how to use the SOFA tool that Laura mentioned. And again, this is a standardized, validated tool that really tries to take as much of the subjectivity out of the decision making. But again, the goal is not to have to do that. And so we're going to do everything we can to avoid that. And it would be a statewide decision. We can't roll it out, one hospital at a time. The call center would be responsible for this as the representative of the state and allocating on behalf of the state.
Thanks.
Great, thank you. And next we'll turn to Julie Fendak. Julie, if you could just let us know what outlet you're associated with, and followed by Sean Griswold and then Algernon Damasa. Julia, you are now unmuted.
Yeah, thank you. I am a newer reporter with KOB. I hope you guys can hear me okay.
Yeah.
Loud and clear.
Okay, good stuff. So I have a question about vaccines. I'm wondering, how do you plan to convince the remaining number of eligible New Mexicans to go ahead and get vaccinated? And then just a two-parter to that, is there a percentage of fully vaccinated people we could get to make a real difference in turning this crisis around?
So you have a two-part question, right? So the first question is, you're asking how can we try to kind of help people get the confidence, the remaining percentage of people that haven't gotten vaccinated. And we are trying a lot at the Department of Health, and same with many community organizations, and people have been trying to get the word out to groups that haven't been vaccinated. But I really think it's a multi-pronged effort of all of us. So, all of you as news people to share that message as well. We have a lot of community organizations sharing the message. At the Department of Health, we have a new program called Better Together, where we're giving funding to local community organizations who are either planning vaccine events or wanting to share their own materials to the community. We also have, if people want materials, that we have a DOH website, that's a community website. I can stick that in the chat, where people can get materials that Department of Health or others have produced, and we can actually make photocopies of that for you, or posters for your offices. So it's a multi-pronged approach, and really, also, we are really encouraging providers to talk to their patients, because they are the #1 trusted group of people who, people actually trust. So we've actually had a lot of people say to us that, yeah, I'm getting my vaccine because my provider talked to me about it 4 times, kind of like David did right now with his patients. I think that is really going to help, and talking to their neighbors or people they trust. But like David said, everyone has to make their own decision. What we're trying to do at the Department of Health is try to make it easier and try to provide the information that people can turn to, that they can trust, and encourage trusted voices in the community. So that's kind of where we're at for that. And sorry, your second, does anyone?
I can start on that one. It was just sort of, what percent of people would have to be vaccinated to really just shut this thing down? And like your first question, they're both things that we desperately wish we knew. This whole idea of herd immunity that everybody used to talk about and abandoned, I think earlier this year, we're just not really sure when and where we cross that threshold where it's just hard for the virus to move from one person to another, because there's so few opportunities to move. Unfortunately, Delta is a whole new strain, much more infectious. We don't have a lot of data about the Delta virus and how that, the kind of advanced sort of level information that we had about the previous, genomes of the virus. And so we're not exactly sure. We know that the more people we get vaccinated, the better we're going to do. We know that states with the bottom 25% of US states in vaccination rates had kids visits to the ER and kids hospitalizations 3.5 times higher than visits for New Mexicans. One of the reasons we're excited about 5 to 11 getting vaccinated, a whole new group, is that while they don't get particularly seriously ill, we know that those kids can get and transmit COVID just as easily as adults. And like influenza, where it took us 82 years to figure out, my gosh, we really need to vaccinate kids. Schools are a place where the virus can be transmitted. I think we're excited about the fact that with COVID, we could also give that vaccination. Now, we don't think kids are actually getting COVID in schools. We think they're getting it in the community, and then we're picking it up because there's extra testing in schools, or they have symptoms and then we're aware of it because they're not coming to school. But I wish I knew the answer, but I can just say, if you're a New Mexican out there listening who hasn't been fully vaccinated yet, you can help. You can help. You're just as important as every other person in the state who's been vaccinated or who remains to be vaccinated in turning the tide. And I'm sure there's thousands and thousands of people who are alive today because of the vaccine, and really encourage those of you who are unvaccinated to choose to be part of that group going forward.
Thank you so much. Next, we will turn to Sean Griswold, followed by Algernon Damasa. And earlier I put hands down, but if you'd like to ask a second question, by all means, feel free to raise your hand again. Sean, you should be unmuted.
Excellent. Hey, thank you very much, everyone, for hosting this and taking my question. I believe my question is going to be directed towards Billy Jimenez, because I'm curious to understand, for hospitals that move into CSC, just to confirm that the state will extend limited legal liability coverage to providers who move to higher levels of care. And if that's the case, can you discuss what kind of legal liability that they could see, and how will hospitals' liability be changed if their applications are approved?
Yeah, thank you for the question. It's very similar to the setup that we had last time in December when we enacted crisis standards of care. So by getting credentialed through the state, providers that are practicing outside of their normal scope of practice can move into the acute care setting and then be covered basically similar to a state employee under the Tort Claims Act and have that protections. So it really allows hospitals to reinforce their own staffing in the hospital setting with physicians and providers who are outside, and they can be protected. So for a hospital, it's going to provide them a lot more ability to mobilize their workforces. And basically it's a setup through the Tort Claims Act where if somebody's acting as an agent of the state, then we treat them as a state employee and they're protected just like a medical provider at UNM might be protected under the Tort Claims Act. And this is through an executive order that's issued by the governor, and then it orders us to establish this credentialing program. We then put an electronic application online, and we'll make that website available to providers within the next day or so. And we will give those providers an opportunity to apply and become credentialed.
Okay, thanks so much. Next, we will turn to Algernon Damasa and followed by Daniel Chacon, and then we'll go back through our second round of questions as needed. Algernon, you are unmuted.
Thank you, everybody. I also have a question about the legal protections that are being provided for recruiting providers to work outside of their regular scope of practice. I'm wondering if the situation, since this spike is different, if we're going to be seeing providers moved up to a higher level of care for treating non-COVID patients, since that seems to be the bigger load this time around, and if that makes the credentialing process or the legal environment any more complex, if that makes sense.
Yeah, that's a great question. And I think that, I'm just thinking about myself. Like if I got called up, if I were in private practice, for example, seeing patients in my office and got called to come work in the hospital where I haven't really done meaningful, significant, prolonged work for, 19 years or something like that, it would be a little bit frightening. I think hospitals will have to, the issue here is that, we had a long discussion about this last week. It's not like we don't have a ventilator. It's that but we do have a shortage of ICU beds. So it doesn't matter if this was last December or now, if you're the person who needs intensive care and a bed's not available, And that is the fundamental problem we're having. And so I think hospitals will likely be creative. Like if they called me up, for example, if I fit into this situation, which I don't, because I already work for the state and also I'm on the faculty at UNM, but if I was in, let's say, Presbyterian, like I used to be, I think those hospital leaders would say, well, you're a geriatrician. We'd like you to particularly focus on the older patients, COVID and non-COVID, in the ICU setting, perhaps. But I don't know, Billy, I don't think the order specifies one way or another. That calling up is a response to the crisis itself we're facing, not the characteristics of individual patients, if I remember correctly.
Yeah, the order is aimed at the shortage itself, and so not just specifically at COVID-related treatment. So I think the order, the executive order and the public health order and the credentialing program definitely provide a broader scope of allowing providers to substitute in and provide that any kind of level of care, quite frankly.
Thanks.
Thanks, everyone. Let's turn next to Daniel Chacon, followed by Julia Goldberg and Julie Frendeck. I think you are looking to ask a second question, but I'll double back and check. First, Daniel Chacon, go ahead and ask.
Thank you all for the opportunity to ask a question. I just want to make sure that I understand what's driving this decision to enact crisis standards of care. Since cases and hospitalizations are lower now than they were in November and December, is it primarily that we have a lot more people in the hospital with non-COVID related illnesses?
I think that it's a great question. And we've talked a lot about this, like what is at the core of this? And I think right now, this week, at the core of this is the lack of nurses to provide direct nursing care to patients in ICUs and general medical surge floors. I think that that we could talk for a long time about whether this very large number of very sick people who don't have COVID is related to the pandemic or not. Most of us think it is. Most of us think that this unprecedented increase in how sick just the non-COVID patients are is related to delays in care. And of course, that delay in care is related to the closing of many healthcare facilities or outpatient offices or lack of follow-up with folks with their providers that's now resulting in more serious disease. Kind of like Jennifer explained when she talked about people going home from the ER, they come back later sicker and, with more complications. I think that happened as well. So I think all roads basically lead back to the coronavirus as the source of our problem right now. It's just that it's manifesting in two different ways. A surge of more people, frankly, than we were expecting to see because of the degree to which the Delta variant spreads, 2 to 3 to 4 times more rapidly than the previous strains that we've seen. And then I think this delay in care. And then remember too, there's always a baseline in care. There's always people, moms having babies and people unfortunately having heart attacks or strokes or GI bleeding or other. I don't want to get too graphic here. I'd go into too much medical detail, but I think it's sort of a little bit of everything, really, in all the different categories that's contributing to this. But I think our pinch point or our real constraint right this minute, unlike the past when it was PPE or it was ventilators or whatever it is, really is our ability to get nurses and the fact that they're in short supply nationally. And so there isn't a big group of them that can just move from a state with not really having trouble with COVID because there aren't too many of those and move to New Mexico to provide care. I don't know, Jennifer, any other thoughts on that one?
Yeah, I think I mentioned it earlier, but I think, as our acuity increases, our case mix index, which is, how we measure acuity in the organization, as that goes up, the length of stay also goes up. So not only are these patients sicker, requiring more resources, but they're also here a lot longer. So, if the average patient was here for 3 days, they're now here 5 days as an example. And so if there's 100+ patients in that scenario, you're looking at significantly more beds being used in that population. So I think that is also contributing to this.
That's a great point about the length of stay. Thanks, Jennifer. I think one other thing that's part of this mix as well, that this time and last time, is when those people are finally ready to move out of the hospital, we're having staffing issues in nursing homes as well, which create delays because the nursing homes don't have as many beds. So that makes it harder for people to transfer from a hospital bed, so we can free that up for the next person into a nursing home where that lower level of care is now appropriate for them. So it's a really complicated system. You know, that whole set of dominoes you used to set up when you were a kid and then just knock one and the others all fell down. Everything in healthcare is connected in that way. And so I think all of those factors are really at play here right now in creating this challenge we're facing.
Thanks, everybody. It looks like Julia Goldberg is interested in asking an additional question, so we'll turn to her. And I don't see anybody else who is with a raised hand at this point. So if you'd like to raise a hand and ask an additional question before we wrap, now's a good moment to do so. Julia, you are unmuted.
Thank you, Matt. I had a quick question for Dr. Petahone and Dr. Scrace. I predict you will not think this is a great question, but just an annoying question. But Dr. Petahone, I noticed last week that the percentages for vaccinated people ages 12 through 17 had dropped. And when I asked the health department, I was told it was because they changed the coding from age group today. But I am not seeing a concomitant change in the adult group, 18 and over, which I assumed there would be if more people were being put into that group. And I don't know if that's just because the percentage increase day to day is so low that it's not going to show up, or if it's just that I can't do the math and it is showing up. So I thought I would ask you rather than keep thinking about it.
Let me just, for those of you who aren't as mathematically inclined as Julia, very simply put, if someone got a shot a year ago when they were 17, they're not 17 now. And so they shouldn't be in that 17-year-old group. And so we are aging our population and regrouping them on a regular basis. And I think what Julia is saying is, hey, I saw the numbers pop down a little bit in that 16, 17 group, but didn't see them go up in the 18 to 24 or whatever group it is, Laura.
Yeah, no, that's thanks so much for noticing that. That's pretty incredible. Yeah, we did have a change in the way it's called Tiberius. So it's a nationwide data system that tracks age groups, race, ethnicity, and also doses. And so what New Mexico actually has such a good data system that we were tracking our own data and not necessarily using the data from Tiberius because there were some duplications. And also we had data, I don't know if you notice on the dashboard, there's like federal data. And so there were certain data sets that we didn't have visibility on, such as the VA doses, and VA has also done children as well in different groups. So then last week or 2 weeks ago, sorry, whenever the thing changed, we got a data set from the department, from the Tiberius CDC set. So really from the VA, from the Department of Defense, all those areas that we really normally didn't have visibility on. And so that changed a bunch of the numbers, including the child set. And then, and as David said as well, we were aging some of the kids out into 18 and up. So that's really where that data difference lies. But I can actually send you, Julia, a whole email that kind of describes the whole set if you would like. Because
I would enjoy that. Thank you.
Okay, I'm pretty sure you would. That's awesome. Maybe you should come work for us, Julia.
Yeah, the other thing, Julia, is if you look at the dashboard, you'll see that the federal doses is really what we're part of what we're talking about here are pretty small, 1/8 of the total doses given in New Mexico. So whatever effect happens there, you'll see in numbers, but its overall effect would be blunted a little bit. But I'm sure you'll find reading the email enjoyable, and we all admire you that you will. Matt, is there anyone else who's raised their hand?
Julia, you still got your hand up. Are you looking to do a follow-up, or is that just?
No, sorry, that's an accident.
No problem. Okay, cool. Well, it looks like we've addressed all the outstanding questions. So with that, I'll just turn it to the panelists for final words.
So we didn't warn Billy and at all about this, or Jennifer, but you have the opportunity, should you choose, to make a few final closing comments. And so we'll go Laura, Billy, Jennifer, and me. So Laura.
Okay, great.
Nice to hear from you. How you doing?
Oh, okay.
No, I'm sorry for playing phone tag. Yes.
Hey, Sean.
Someone's got a live mic.
It's Sean.
Sean has live mic. Okay.
Oh, he's muted now. Go ahead.
Okay, thanks. Well, I mean, I think thanks everyone for being on this call and once again doing all you do every week. I just want to, I think this particular press conference really showed like the link between our state getting vaccinated and then how that affects hospitalizations and deaths. And so I think the next part of this pandemic is up to us as a community, as a state, as to, you know, how much we all decide to get vaccinated and try to end this pandemic, because really it is up, we have the science now, we know how to fight this with the vaccine. And so to me, it's about how we think about as a community coming together and getting vaccinated to prevent more hospitalizations, more deaths, more difficulties in the hospital. So that's all I have to say, is just thanks for getting the message out there for vaccinating people.
Thanks everyone for having me on as a guest panelist today on the press conference. Just want to say that, you know, in our discussions in preparation for releasing the public health order, we talked about how both the governor's executive order and the public health order is really about creating a pathway to crisis standards of care, a standardized approach by which a hospital system or individual providers can move towards, you know, altering their standard of care in a methodical way. And so I just wanted to reiterate that, you know, it's about exhausting a set of resources, whether it means focusing on medically necessary procedures or mobilizing medical staffs. What the order today is intended to do is create a pathway for that differing level of care.
Thank you, Billy. Jennifer.
Thank you for having me. And I just think we need to reiterate that now more than ever, the vaccines are necessary. We don't want to have to take this any further than where we're at. And I think if we can work on getting our friends and families vaccinated, we can hopefully turn this curve.
Thanks. And I'll just close. I'm particularly appreciative of having both Billy and Jennifer here today. You know, there are hundreds of Billys and Jennifers who work every day really hard behind the scenes to fight this pandemic, be it at a bedside in a hospital or figuring out the legal implications of what we do next. Billy is not always everyone's favorite person because he handles the enforcement arm at the Department of Health of violations of the public health order, although he got to wear a tuxedo this summer on the lottery show because he also handled those winners from the vaccine lottery. Jennifer managing her role as a nursing leader, wife and mom, and then also having to deal with the the transfer center, helping DOH, working for the state to allow us to be one big delivery system rather than a fragmented network. And so all of these folks really work long hours and meet frequently on weekends and holidays, although we're trying to cut back on holidays, right, team? But you really have a dedicated group of folks in state government and in our whole healthcare system in the state. And we just ask you to get the word out one more time to every unvaccinated individual or people due for boosters or, as well, to really consider vaccination and to remind people to keep getting healthcare. We're not asking everyone to put the brakes on healthcare, because part of that slowdown last year has resulted in some delayed care this year. And so we just ask it. Thank you for your help as media partners. Appreciate you getting the word out. We'll be back next week. I'm kind of hoping we get back to our regular time schedule on Wednesday, and we'll have more information. And of course, as always, we're available to answer questions between now and then. So thanks, Matt. And I think we're ready to call it a day.
Have a great afternoon, everybody.
Thank you.